Peter, thank you very much indeed. That was wonderful. You ranged far and wide over the landscape of contemporary genomics and made it, I think, for all of us, magnificently clear and understandable. And I must say that you clearly rose effortlessly to the pressure of the spirit of the prestigious Romanes lecture. And you can see why we are proud of Peter and his research team in Oxford, and nowhere more so than in St. Anne's College, where Peter is a fellow. You've given us great insight into your research and the research of your colleagues at the Wellcome Trust Centre for Human Genetics. Research, as you said, which is already providing and will increasingly provide both challenges and opportunities. We will now, in a panel discussion, examine the impact of the gene revolution on wider 21st century society in the next stage of this Oxford-London lecture. And it gives me great pleasure to hand over to Lionel Barber, editor of the Financial Times, our media partners in this Oxford-London lecture. Lionel is a graduate of the University of Oxford. He began his career in journalism first at The Scotsman and then at the Sunday Times, and in 1981 was named Young Journalist of the Year in the British Press Awards. He joined the FT as a business reporter in 1985, and since becoming editor in 2005, since he became editor in 2005, the Financial Times has won numerous global awards, including 3 Newspaper of the Year awards. And so, Lionel, may I invite you to the stage and hand over to you to introduce the panelists.
Thank you, Vice-Chancellor. Can I just say on a personal note that as editor of the Financial Times, I'm absolutely delighted to be, and we are delighted to be associated with this prestigious lecture. We're committed, as the Vice-Chancellor said at the Financial Times, to explaining the modern world. And I think after this wonderful lecture, I know now that we need to revise our famous advertising slogan, which used to be, "We live in financial times." It's now going to be, "We live in genomic times." Right? We have a really prestigious and expert panel, so I'd invite the panelists to join me on stage. First, Professor Sir John Bell, who's the Regius Professor of Medicine at the University of Oxford and a founder of the Oxford Wellcome Trust Centre for Human Genetics. Second, the Right Honourable Stephen Dorrell, Chairman of the House of Commons Health Select Committee and a former Secretary of State for Health. Next, Professor Nazneen Rahman, Head of the Cancer Genetics Clinical Unit at the Royal Marsden NHS Foundation Trust and Chair of the Section of Cancer Genetics at the Institute of Cancer Research. Finally, Dr. Jeff Watts, the renowned writer and broadcaster, and currently a member of the Nuffield Council on Bioethics, former member too of the UK Government's Human Genetics Commission. Now I'm going to moderate this session with a very light hand, and then after a short while we will invite questions from the audience. Can we start off, Professor Donnelly, with a better assessment of how you believe healthcare, what is going to be the big, you're going to see the biggest impact of the kind of genomic revolution that you described in your lecture?
I think in the short term, two of the areas where we're already seeing an impact and it promises that we'll see rather more are cancer genetics, and the idea that through studying individual tumors, the genetics of individual tumors, we can target therapies and treatments. And actually the area of bacteria and bugs, the use of genetics there, I think will also be important, and one of the things we'll see relatively quickly.
Superbugs?
Well, superbugs are a particular problem, and genetics allows us to understand the process by which antibiotic resistance is developed in bugs.
Professor Donnelly talked about cancer. You're obviously an expert, a practitioner as well. Can you give us perhaps a greater understanding of how you think these changes will impact?
Yes, as Peter was saying in his lecture, what the genetics is allowing us to do, both in the cancer itself and also in the individual who has the cancer, is to have a better idea of what that cancer consists of, and that allows us to have tailored treatments specifically for the genetic changes in that cancer. And then for the individual, we can identify things in their genetic makeup that maybe has led to that cancer occurring in the first place, which in turn may allow us to start to develop preventative measures, because we can predict whether or not they're going to get cancer and have a window of opportunity to potentially alter that.
Any particular types of cancer that you think are conducive to treatment earlier through these advances in science?
All cancer has some kind of genetic basis, so it will be of relevance to all cancer. But certainly breast cancer is an area where we're already using genetics routinely in identifying people who are at risk. And as we were seeing with the melanomas, there are already targeted therapies to certain cancers directed at changes within the tumours themselves. So we're already doing that in a number of cancers, and I think it's going to be an area that's going to really explode over the next few years.
Well, Dr. Bell, as we saw in the on the screen earlier, there was some fairly excited coverage back in 2000 on the kind of changes we could expect to see in science translated into cancer treatment. But how fast is it going to come? Is it next 2 years, 3 years, 5 years?
So I've got what I call a 20-year rule, which most people break when they talk to newspapers. But the 20-year rule takes 20 years from a fundamental discovery to the time when it's routinely used in the clinic. And if you take the genome, we're 10 years in. But it doesn't all happen at once. We're starting to see increasingly application of these tools. You saw some of the data around pharmacogenetics. And it's beginning to infiltrate the thinking around clinical practice and our understanding of disease. So I think we're going to see increasing use over the next decade, to the point where it'll be in common parlance and common usage, I think, within the next decade.
And can you talk a little bit more about the area of bacteria rather than just cancer?
So the story on bacteria is that for a long time we've been able to identify the type of bacteria by looking down microscopes and seeing their shape and the way they stain. But we've also known that they have widely different behaviors. Some of them are very aggressive, some of them are less aggressive, some of them are resistant to antimicrobial drugs, some are not. And it'll be possible, using genetics, to have a much more granular understanding of microbes and how they operate, as well as to track the clinical epidemiology, the way they're being transmitted in patient populations. Diseases like tuberculosis, for example, it'll be much easier to track outbreaks of tuberculosis when one understands the genetics.
Now, Professor Donnelly also alluded to some very profound ethical issues which are raised by these advances in genomic research. Let's explore that. There'll be some questions on this from the floor, but give us some examples. For example, how do you see the implications for genetic testing of embryos, for example, or fetuses? Dr. Watts.
Yes, I mean, the whole field of genetics does raise a whole raft of ethical issues, and including in testing for embryos. Pre-implantation genetic diagnosis, for example, has raised all kinds of possibilities in terms of the choices that we have for our future, for our offspring, and the genetic content of the future of our offspring. And I think the classic story, I think, with ethics in most areas of life is that while in theory we could actually think through all the implications in advance and work them out, so that when the actual possibility of doing something is available, we've actually decided what our ethical position is. We've taken the right moves, we've got the right positions. In practice, time and again what happens is that we are confronted with someone has done something and we haven't prepared ourselves ethically for it. And I think we're going to be seeing that again and again in terms of this area of medicine. This will be no different from other areas of medicine. It's not until we're actually confronted with the dilemma that we actually then have to think, what on earth are we going to do?
We're going to turn to Stephen Dorrell and ask him what kind of legislation may be needed, perhaps, to cover these areas. Is this something that's on your mind at the moment, and your colleagues in the committee?
I think, like everyone else, we're coming to terms with the fact that these are issues we're going to have to address rather than having addressed them. The first instinct is to think, gosh, this is very difficult. Wasn't the world simpler when we didn't have this knowledge? But you can't uninvent it. Ignorance is never the answer. And so what we then have to do is to work out how, as you were saying, how you deal with these issues as practical issues when there's a practical decision to be made, given the knowledge that we now have and which we can expect to develop in the years ahead.
Consumer organizations in this country are already raising questions about possible discrimination on the basis of genetic research. Do you think we should copy the United States in adopting legislation, something alluded to by Professor Donnelly in his lecture?
No, I don't, because I don't think that one of the comments that Professor Donnelly made in his lecture was to imply that somehow discriminating on the basis of genetic knowledge was something that we should always regard as wrong. But actually, the whole point of increased knowledge of the genome is to allow us to discriminate in a way that can bring medical and other benefits. So the process of discrimination is part of what improved genetic understanding of the genome is about, it seems to me. And that would be a rather good example. If we say we're not allowed ever to discriminate on grounds of genetic knowledge, would be to say we prefer ignorance, when that can't be right.
Dr. Bell, do you agree?
Yeah, so I think there's a very interesting transatlantic philosophical difference here, because there is the diagnostic tests that go along with deciding whether you get a drug or don't get a drug based on whether you respond or not is viewed often in Europe as being a real opportunity to provide you an opportunity, if you test in the right way, to get a drug that you wouldn't otherwise get. In America, those tests are viewed to be bad because they're viewed as being an opportunity to prevent you from getting a drug that you should be entitled to get, whether it works or not. So, in fact, there are huge differences in the way
I think I
people...
follow you. Dr. Westwood?
The discrimination issue is a real live one. And it's perfectly true, we have no specific legislation over here, and it doesn't look very likely. I would have thought in the near future we're going to get it. The legal position when it comes to existing kinds of disability, anti-disability discrimination that we've got, is uncertain. A lot of it, whether it applies to someone who is simply got genetic... Sorry? Oh, is the microphone not working? Someone can come to my aid. Well, yes, I say, while someone is coming to fix this. The current position is that there is legislation of a general nature about discriminating against people with disabilities, but whether that applied to someone who, for example, had a particular genetic makeup, which meant they were predisposed in the future to some kind of disorder, is another matter. And even if people did attempt to brings some kind of action under that law, would almost certainly end up going to Europe or somewhere to a very high court where it could be thoroughly worked out. But one worrisome area, of course, is outside of medicine, which is in DNA fingerprinting, where we are working ourselves into an extraordinarily discriminating position there, because the pattern of people whose DNA fingerprints are now stored on the police database, which has simply grown more or less out of control, like Topsy, is very, very unsatisfactory. That really should be debated by Parliament, which I don't think it ever has been yet.
Professor Roberts?
I think sometimes the terms we use, we have to be careful with them. So discrimination is almost always a pejorative term. But actually what we're talking about is, if you call it stratification, people are much more comfortable with it. So what we're often doing is we are stratifying people, and that may or may not be for their benefit. But often when you're doing something, a test like that, you may find something that puts them in a higher risk category, but equally as likely, you'll put them in a lower risk category. And for insurance, for example, that may actually result in them being at a lower risk. Or you may be able to stratify them according to treatment. And so I think we have to be careful when we're using this discriminatory power. That's often very helpful in a medical setting. Being able to do that then allows us this kind of personalised medicine. So I think that sometimes we have to be careful in that. I think also in terms of things like prenatal diagnosis and pre-implantation diagnosis, that is already a reality. We already do that for quite a lot of different types of conditions. I think what's changed is the scale and the way that that's now become part of general sort of sensibilities of the public, of policy. But we've been doing that in genetics for a long time for a number of different diseases. What this now will allow us to do, this kind of new technology, is to be able to do more genetic tests, and that will bring us new challenges. But society as a whole has already embraced the concept of, under certain conditions, being able to do both prenatal and pre-implantation diagnosis.
Okay, I'd like to just go a little bit further into the moral maze by asking each panel member very quickly, do they believe, first, that it will be ever routine to read an individual's genome and have that part just available as part of their medical records? Stephen Doran?
I can't immediately see why, as a patient, I wouldn't want to have that opportunity and wouldn't want my clinicians to have that opportunity, because I think that understanding my human genome, I'm from a humanities background, so I'm the worst person to make this kind of judgment, but my starting point would be that if that knowledge in the hands of the clinician allows them to offer higher quality care to the patient, then that information should be available to them, because, as I go back to my point, the alternative is to prefer ignorance.
Okay, so does anybody on this panel disagree with Stephen Doran?
That's the first time in my life.
Very good. Very good.
I think it's really a question of when. A few years ago, when I was a member of the Human Genetics Commission, we were asked by the government to consider the issue of whether or not we should actually be routinely doing this kind of sequencing on newborn babies. It became known rather irreverently as the Barcoding Babies project. We all thought this was a waste of time because it was fairly obvious what the answer was now. This is hugely expensive, wouldn't tell you a great deal, complete waste of money. But actually, you know, the pace at which, as we saw from Peter, the cost of doing these kind of analyses is dropping. The rate at which we're accumulating information, which is probably eventually going to give us much more robust predictive power than we've got at the moment, is moving so rapidly that I would have thought it'd be very unlikely we wouldn't get to a position where we would see this as routine.
Okay, so who should or should not have access to this information? Starting with Professor Donnelly.
I think that's a very good question. If it's done as part of healthcare, then one would hope that the medical professional who is looking after a given patient have access to the information. I think an individual should have access to their own information in their own DNA, should they wish to avail themselves of that.
Members of the family?
Not obviously, I wouldn't have thought, but the doctors amongst us deal, I think, much more regularly with issues. I think, as Professor Rahman said, many of the important questions of principle aren't so new here. It's already the case that there are genetic tests, and you can learn from testing one individual something that's relevant for other family members. It's something that has to be grappled with by doctors at the moment.
How are you going to grapple with this?
So we do already deal with that for a number of different tests. I think in some ways it might become easier because currently, because genetic testing is very expensive and arduous, we always want to get the test, we want to do as little testing as possible. So we want to test one family member, so we find out what we're looking for, and then we can only look at that one specific thing in everybody else. When genetic testing becomes cheap and routine, we don't really need to go to the family member. In a lot of cases, we can just do it on the individual in front of us. So we'll actually, in many situations, it may not become so relevant to have the access to the family information.
And what about the insurance company?
I think so many different things are changing in terms of, I think the individual needs to have their information. It may be everyone's going to put it on their Facebook page because, you know, people
I knew
don't
we
care,
were going to
you know.
get to Facebook or Google at some point. Thank you very much. Dr. Bell, is there anybody who's not going to have access to this?
You can buy an iPhone app that'll hold your genome. So I think people could choose not to have it done, but I can't imagine why they would choose that. It's going to be cheap, very, very cheap. It's going to be accessible to everybody, and there will be, I think, significant health benefits to knowing what your genome holds. I think the issue about how widely you distribute it, and insurance is a good example. You know, the truth is the insurance companies have a very hard time dealing with blood pressure and cholesterol, let alone a human genome. So I think people who get in a sweat that they're going to suddenly change their business model don't really need to worry too much about it. So I think it has many, many more benefits than it has risks.
Stephen Doran?
I think that clearly the thinking through the implications of genetic knowledge for insurance and and how the insurance industry is going to respond to that is one of the issues. It's an example of an area where we're just starting down a road where we've a long way to travel.
Right. This is a perfect segue to ask Baroness Mary Warnock, who is here with us in the front of the audience, perhaps to ask her question. Do we have a microphone? Do we have if we just wait for the microphone. Just here. Yeah.
Professor Donnelly did mention this in his lecture, but I wanted to ask what advances there have been in identifying genetic influences on mental illness, because it seems to me that the possibility of discrimination, particularly among students and undergraduates, is enormous if we could know, but are not told about students' liability to mental illness, to depression, say, or schizophrenia.
It's a very good question. Different, in ways we wouldn't necessarily have predicted in advance, different classes of disease have been easier and more difficult to try and get to the bottom of the genetics of. And it's certainly the case that the mental health disorders, schizophrenia, depression, and so on, they've proved very difficult in terms of understanding the genetics. It's unfortunate in some ways because that's an area where genetics could conceivably make a huge difference. There are no direct ways of studying what goes on when someone gets schizophrenia and so on, but if we could get clues from genetics, that would be very helpful. I think we're just in the early stages. Those diseases are lagging a little bit behind many of the others I spoke of. There are now a few findings for schizophrenia, some for diseases like autism and depression, but rather fewer than for other diseases. So that's from the scientific point of view. I think, as you say, there are then really important issues in terms of how that information is used if people are susceptible. At the moment, most of the things we're finding have themselves very small effects on risk. So even the variants that have been discovered associated with schizophrenia, they might increase someone's chance of getting the disease by a few percent. So knowledge of that about an individual probably won't change, or it certainly shouldn't change if it was understood well, the way we react to the individual. But as I said, the big hope is that in time, it'll help us understand the diseases much more. But you're absolutely right to raise some of the important questions about use of the information.
Now, I am going to raise the question about the impact on the NHS, but before I do so, there is one other ethical question, which I think is rather fascinating to discuss, which is What about situations in which an individual is identified as being at higher risk of, say, a particular disease, but chooses not to take reasonable steps to ameliorate that risk? Dr. Bell, what would you say?
Well, that
on
happens all the time in another world. There are lots of people puffing cigarettes on the street all the time, and that is a much bigger risk than any genetic factor we found outside the monogenic diseases. And society takes the view that if that's what they want to do, that's what they want to do. I would be surprised if our view about genetics will be any different.
Would you agree?
Yes, I would agree, yeah.
So it's the smoking test, essentially. Well, I thought that was rather difficult. But what do I know? So let's go to another distinguished member of the audience, Lady Carolyn Roberts, who's the chair of the Ethox Foundation, which works to promote medical ethics amongst healthcare professionals.
Hello. I'd like to thank Professor Donnelly for an excellent lecture, really good, because I'm not a geneticist and it was very understandable, so thank you very much. My question is about education. Do the panel agree that one of the issues to be addressed by the gene revolution is for all NHS professionals, hospital doctors, GPs, nurses, to have education and training in the ethical issues arising from genetic advances?
Would you like to take that, Dr. Ramo?
Sorry, did you say with respect to the ethical issues?
Yes.
I think in many ways the ethical issues are very similar to many of the other things that we deal with in genetics. And in fact, we do quite a lot of genetic diagnoses in clinical practice. It's just we're using a surrogate for them. You can do all sorts of genetic diagnoses by clinically looking at a patient or doing some other kind of blood test. And we're often, if we're finding somebody's got a high blood pressure at a young age, that actually does put their family members at risk. And so we're already, there is quite a lot of this already in the health service. I think generally, an appreciation of ethics and these kinds of discussions are helpful for doctors, and there's certainly a lot more of that in medical education than there was when I trained, and I think that that's beneficial. I think sometimes it is overplayed how different the issues are with respect to genetics compared to other branches of medicine, and I think there's a lot more commonality than people often appreciate.
But do you think there needs to be a much greater degree of training now we're in the middle of this revolution?
I think in terms of the use of genetics, yes, I think both for patients and for clinicians, better education and more people, it does raise uncomfortableness in a lot of ways, and I think education can address that. But I think quite a lot of the use of the genetic information is going to come down to having protocols that will have to be developed by specialists in any given area that a doctor, a GP or whatever will use and access in the same way they would use any other kind of genetic information, any other kind of clinical information. A lot of it will be like that, I think.
And Dr. Watts, how do you see medical training changing as a result of these advances?
Well, I mean, medicine, there's nothing new in a sense about the fact that doctors may be wrestling to keep up with genetics, because the whole basis of medicine is moving so rapidly that in a sense in every specialty, doctors are constantly having to run simply to keep up with what's going on at the moment. But I think, yes, I mean, I think they will, as genetics moves more and more into clinics, more and more they will have to come to terms with that. But that's not unusual. I mean, this is something that medicine, as a scientific, allegedly, I think, scientific profession, is accustomed to. Science, the whole point about science is you're constantly questioning what you know, what you understand, what you do, developing new ways of doing things. So the very essence of becoming a doctor in an age of scientific medicine is to be accustomed to this idea that what you did yesterday is not necessarily what you're going to do tomorrow. So genetics is just one more example, well, a pressing one, but one more example of a continuing dilemma.
Steady as she goes?
Yes, I think the other aspect of education, which is going to be transformed in the next decade, is that genetics is going to give us, for the first time, an understanding of disease which is mechanistic, not observational. So when you go to see your GP, he looks at you, you're coughing a bit, and he says, well, you know, you got a cough, have some cough medicine. What we will understand is, because we can understand the mechanistic pathways, we will actually understand disease in very, very different ways, and that's going to have to transform the way we teach medical students and doctors how to think about the diseases that are in front of them.
Professor Donnelly, let's hear a little bit more about that, how teaching methods will change.
So I haven't had a medical education. I'm not so well placed to judge. So I think Professor Bell's right that part of what will happen is that we will think about diseases differently. I think we're already thinking, not that it's my field, but we're already thinking differently about cancer tumours. Some breast cancers have got more in common with cancers in other organs than they do with other breast cancers. And that's the kind of stratification that I think will become much more routine and will make a fairly profound effect on how we think about medicine.
Any other thoughts on just the way medicine is taught, how that is going to change? I'm sure there are lots of medical students in the audience.
Well, I think sort of going on from what both Peter and John were saying, if you're thinking about it on a mechanistic basis, generally how we're taught in medicine is very much kind of organ-based. Let's learn about the lung now or the kidneys, whereas we might have to learn and think about, well, let's think about this mechanism or this kind of genetic pathway and how that impacts. How that then, at the end of the day, you see a patient in front of you who has symptoms, so you still have to go back to fitting that together with the person who's in front of you. So I think it's going to be extremely exciting, and I hope it's going to attract lots of people into medicine to sort of to sort of make use of this. And I think it's going to be quite dynamic. We're going to have to see, and it'll be different for different fields, I think.
Let's talk a little bit more about the political context. As we know, we've had I'm going to murder a metaphor here, the bonfire of the Quangos. I'd be interested to know whether the panel thinks that there is a place for more or less regulation in this area of genetic research. For example, the genetic testing of embryos or fetuses. Do you have any thoughts on that as an elected representative of the people?
Quite a lot of thoughts is the answer. And it's an area which we've, particularly in the context of the bonfire of Quangos, needs to be thought through.
Which you support.
Of course.
Yes.
In the Whip's office, I used to have a saying, it's the government's policy, it must be right. But as a chairman of a select committee, I can be a bit more discriminating. Whether it doesn't seem to me actually it matters too much the precise structure of the body. What is essential is that something takes forward the work that the HFEA has done over thinking through the ethical questions around the treatment of the
Fertilization and Embryology Authority.
Indeed.
Yeah.
And that body, I think, has had a very distinguished history, including in its early period with Mary in charge of it, in thinking through the application of ethics to a very difficult area of medicine. And I'm not in favour of those kind of issues being dealt with in that House of Commons without a mediation through a rather calmer process.
Dr. Bell?
Right. Well, I think it's had an enormously successful track record. This is the HFEA. But the world has moved on, and I think there's an interesting question about whether it is the right structure to manage these questions. Certainly from the research perspective, it's clear to me that there would be other ways of managing some of the issues around research governance. Recommendations made by the Academy of Medical Sciences recently, I think, suggest that there might be a mechanism to hold those within a more general research regulator, and those are ideas I obviously endorse. So I think there's some more discussion to go as to whether it should be changed or not.
Thank you. I'm very conscious of time, so I'm going to ask each of the panelists, it's a sort of Financial Times quiz. Well, you said there was going to be a quiz. I'm going to ask each of them, each of the panelists to name one main challenge, and particularly one main opportunity for society arising from the gene revolution that you've described so eloquently this evening. Should we go to Stephen Dorrell to start?
I think one of the things we haven't discussed, and which I think is one of the, as I understand it, and I emphasize as somebody from a humanities background, one of the major implications of this revolution is the phrase that Professor Donnelly used, personalized medicine, and the implications of that for the development, the future development of the pharmaceutical industry and the application of pharmaceuticals in medicine. I think that has, as I understand it, a huge implication for the industry, a huge implication for publicly funded healthcare because of the costs of personalized medicine, and thinking through how those are going to be absorbed and applied is one of the policy challenges presented in this area. But again, I go back to my starting point, which is that the knowledge is something we should celebrate and seek to apply, not go away behind a stone and think it's all too difficult.
Well, I think that's very timely, given that Pfizer, the big pharmaceutical company from America, has announced today that it's closing its research facility in Kent, in Sandwich, Kent, which is somewhat of a blow, not just to inward investment, but to our research base in this country. Dr. Bell, an opportunity, a challenge?
So he stole my opportunity, but anyway, that's okay. There are lots of opportunities here. I think this concept that we will now be able to define disease, all common diseases, completely differently and mechanistically is the huge opportunity. We have the whole history of medicine. We have been struggling to better predict natural history of disease, choose better therapies, manage patients better. And we've been doing it in the dark without any idea about what the biological events that underpin disease are. And now, for the first time ever, we've got an opportunity to change the way we think about disease. And I think it's an enormous opportunity. My big challenge is I don't know quite how the NHS is going to cope with this.
Dr. Watts?
The challenge that I would pick up, I think, is that we very often underestimate the extent to which people actually understand the scientific basis of all this. My sister-in-law is a very intelligent woman, 2 degrees, a lifelong teacher, and a year or so ago said to me, I keep reading all this stuff about genes. Have we all got genes? And likewise, I think there's someone interviewed on the other day, or referred to on a radio interview, talking about GM crops, saying that he didn't want to eat crops with genes in them. And when people have this kind of level of misunderstanding, that shows you that when you're talking one level about the highfalutin ethics, the next minute is this fundamental misunderstanding. It is a gap there to be crossed. As far as the opportunity is concerned, I think maybe it's the self-evident one, that we have a chance to actually make predictions for ourselves about the future, which are not deterministic. It's not as if because you've got a gene for this or a gene for that, with a few exceptions, you are inevitably going to suffer certain consequences. What you're told is you've got an increased chance of them, and you can also being told at the same time there are possibilities of intervening to change something about the way you're living, which are going to reduce those risks. So it offers the possibility of a much more rational approach to our future health than we've had before. An opportunity, but in itself too, I mean, I think also a challenge.
Professor Rahman?
So with respect to challenge, I think that there's no doubt that technically it's going to be feasible to read the genomes of individuals relatively soon and relatively cheaply. But actually, in terms of interpreting what that information means, we're really right at the very, very, very beginning. And we can have the same code, and still we're seeing different implications for that. And all of the risks that we are currently using have been identified in particular contexts. So for particular cancer genes, as Peter was saying, there's a high risk of having cancer if you've got a BRCA1 gene, but we identified that in the context of families. Actually, if you're looking at individuals just in the population, we don't know whether those risks actually apply. In fact, we do know that they're less in that context. So what the actual risk is in the context in which you've actually identified it is different, and we're really only at the beginning of that, and we're going to have to do a huge amount of research to make sure that the information that we're giving based on that genetic information is the correct one. So that's going to be a huge challenge. I would agree with, I think we'll move along and you can talk about some opportunities.
Professor Donnelly, finally.
I talked quite a bit about opportunities in my talk, so I don't think I'll go over those again. I agree with the challenge, and it's back to, as it were, my academic homeland of making sense of the huge amounts of information in our DNA. And as Professor Rahman said, actually there's a lot of information that's not encoded in the letters, and we're only beginning to understand that. But you pick that challenge, I'll pick another one. And again, to come back to something in my talk, it's the challenge of making sure there's a kind of joined up path or a bridge between the basic research and the clinic. And as I said, we've been very fortunate in the UK that the NHS have worked very hard to facilitate and to fund work across that bridge, but it's something we need to be really, really careful about and work very hard to make sure that where there are exciting possibilities in the basic science, that they can move as quickly as possible. And I completely agree, it's 10 or 20 or even more years, but we want to be facilitating that, and that's a really important challenge.
Thank you. Ladies and gentlemen, I'd ask you to thank not just our speaker tonight, but also our distinguished panel of experts for what I thought was a really stimulating discussion, and thank you for the questions.
Lionel, thank you very much indeed, and panel, thank you, and ladies and gentlemen, on behalf of all of you, I want to offer a very big vote of thanks to Professor Peter Donnelly for giving the first ever Oxford-London lecture in association with the Financial Times. And as I said at the beginning, this evening was the first in what is hoped to be an annual event and a major and influential landmark in London. In the future, we hope to have an opportunity to bring some of the other great work that is going on in Oxford, whether in medicine and science, as we've seen tonight, or in other areas that we hold dear in Oxford, the humanities, the social sciences. So I want to thank you all for coming this evening, and I hope to see you all at next year's lecture in 2012. But this evening does not end at this point. I want to invite you all to join us for a reception in the room directly behind this lecture theatre. You will have an opportunity at that point to buttonhole members of the panel, to ask questions, to disagree, but more importantly, to have some refreshments. And so, ladies and gentlemen, once again, thank you all for being here tonight. And thank you for supporting the University of Oxford. Thank you.